And that very investigation by Anas Areme Yao Anas will be premiered here on this very platform 7 p.m. And so please do make a date. And then you get to see the incisive revelations that were made in that very video. In the meantime, though, on my banner today, we have to do a lot more discussions on the Millennium Development Goals, and a concern for many advocates as well as health experts in our country is whether Ghana can meet the Millennium Development Goals 4 and 5. And we know that these are expected to reduce maternal deaths and also children mortalities. And so, well, let's see how it goes. In the meantime, though, we have in the studio Dr. Linda Van Otu. She is the director for the Greater Accra Region's Ghana Health Service, and we say thanks for joining us.
You're welcome.
Right. But as far as the Millennium Development Goals are concerned, what strides have we made the last couple of years, especially now we're in 2015? We started mentioning it how many years ago?
Good morning to you and to our dear listeners. And thank you for the opportunity to discuss a very important issue, not just for families, but for the country and also for the world. We have made some strides. Yes, you're talking about our child care, you're talking about care of the mother. So if you like, we're talking about pregnancy, we're talking about the outcomes of pregnancy and what happens to the mother and the child. We have tried because we were supposed to reduce the maternal deaths, our child deaths, the figures that we recorded in 1990 and then to 2015 for the children by 2/3. And then for the mothers by 3/4. You know, it's not so easy saying that we are reducing a maternal death or a child death. So a lot of things had to go in, and that is why we were given such a long period, because it would need time, it would need the efforts of not just the healthcare service provider or the health sector, but other sectors as well. But if you look at our figures and look at how many women are dying per 100,000, that is how we measure it, per 100,000, then you can say that we have reduced. But then we have not yet reached where we were supposed to reach as a country in terms of looking at the the Millennium Development Goals achievement. Because 2015 is the year, and we should have been around 185, thereabouts by now. But we are not yet there. We are not there because there are so many issues that come into play. And also there are variations in terms of within a region and then within the country between regions. So that is how it is. But we have moved on. We have been able to increase the number of women who are pregnant who come to us. We have been able to increase the number of women who receive interventions that are available to help to improve maternal survival. We have been able to come up with policies, we've been able to come up with strategies to address child care. And therefore we have moved. But as to the numbers, we have not yet reached the number that we are supposed to reach. But we still have a few more months in the year, isn't it? And we are trying very hard to reduce, if not to the level, at least to bring it down from where it is now.
Over the last decade and a half, we've seen consistent injection of capital, or if not resources, into improving, as far as these very goals 4 and 5. These efforts that have been made, they've been concerted, haven't they?
Yeah.
How consistently have they come in such a way that they've helped in meeting the objectives for which we would have assumed would reduce the maternal deaths and the other ones we're talking about?
Okay, I think I will answer this by looking at the various areas that the resources have come in. You know, we need human resource, first of all.
That's technical assistance?
Yes, technical assistance. And there's been a lot of training in terms of bringing the capacity of the health staff up to address these issues that lead to either maternal death or child death. So, for example, you find that we have what we call the newborn care. We have what you call the care of the pregnant woman. We have what we call the life-saving skills. We have all these that help to address these issues. So a lot of staff have been trained to be more proficient in using whatever protocols are available to address that. Again, there's been a lot of input into developing the protocols. And let me use another example. If a woman comes and her blood pressure is high, there is a protocol to go through in terms of managing that person. And would need the staff to know exactly what to do, and also to make those protocols available, and to have some even pasted in the wards, so that when a woman comes in labor, the midwife who is attending to this woman or whoever is there would know exactly what to do. So resources have gone into that. Again, we need the logistics to work with. We need the equipment to work with. And there was what we call the AMONC assessment, which looks at the structures that are in place to address maternal and newborn health issues, which means that if a woman goes to a hospital, do they have, if they have to perform cesarean section, do they have the things that they will need to perform the cesarean section? If they have to do blood transfusion, do they have what it takes? So that assessment was done, and whatever was found was disseminated. So we have dissemination of these assessments so that we know if we have 100 facilities that have to perform cesarean sections, maybe 90 of them have what we need, 10 of them need to improve. And based on that, inputs were made. So in terms of human resource trainings have gone on, in terms of getting the logistics to work, also money has gone in to get these things to be there. Although we cannot say that every facility has everything. It's an ongoing process. So once you know what is pertaining in your facility, you make the effort to try and improve. So if you have people coming and they are bleeding, you need to now have access to blood. So if the assessment said that you did not have that, now this is what you have to do. Or you link up with other places that can do that. Again, the other thing we do is to look at our records. And therefore, there's been a lot of training in terms of people identifying through the records that they make, what is it that is happening and how can we improve. So now we can validate our reports. And as a country, we put all our reports together in what we call the DIMS, District Health Information Management Systems. So that has also been improved, and it is still ongoing. So when you key in everything that is happening in your district or in your facility, it goes to a central place so that we can look at it as a country to see what we are doing. Although a district or a facility can also look at what it is doing, and the region can take a look at what the region is doing.
At what point do we have to say, for all these concerted efforts that have been undertaken, these have also filtered through to the private sector? Because for the informal sector, where we have private health practitioners and providers, we've had some makeshift, whether they are structures or procedures of perhaps undertaking some of these treatments for maternal health delivery.
Yes, we don't do it
in isolation.
Yes, we do it with the private sector, but it can be better. We do it in the private sector because we even involve them in our trainings. If we're having a training, we don't just do it for the Ghana Health Service staff. We involve, for example, 37. We involve the police. We involve other facilities that are around. And we need to do this because we refer. Either they refer to us or we refer to them. And the woman can decide to go anywhere. So if she decides to go to a private facility, we should be sure that she will get a good care when she gets there. So we involve them. And then there's also the public-private partnership, and that is key as well. So we don't just do it for the Ghana Health Service. And then when we are putting our reports together, we don't just look at people who came to Ghana Health facilities or government facilities, but we look at people who went to facilities within a district or within a region. And for us in Greater Accra, it even includes Kolebu. Although Kolebu is not under my jurisdiction directly, but we look at what is happening in Kolebu as well, because we have to pull all these together. However, I would say that there's a need to improve upon that. More people in our private facilities have to be trained. If we are training on let's say, protocols to take care of the newborn, we need to involve more of them, because the government institutions do not take care of 100% of the people who have to come to the hospitals.
For a region which, well, has suffered a number of outbreaks of cholera and other incidents over the last couple of years, how has the epidemiology of some of those ailments tend to influence gestational periods for mothers?
You mean the environment and all that?
Yes.
Yes. You see, that is a very important question. It's important because it's not just the environment, but even the road and telecom.
You're talking about access?
Yes, access, you know, if a person decides
and communication.
Yes, communication, access. If she decides to go to the hospital, but where she is very far away, and we don't have a lot of cars plying that road, then she will be delayed. If it is that the road is very bad, then it will be difficult for her to get there. Now, access to water has been found to also have an effect on maternal health and on newborn health as well. And fortunately for us in Greater Accra, you may not have to carry a bucket and walk to a very far away place, although people do not have access to very good water, and that is why we had the cholera. So all these things have effect on our maternal health, on our newborn health as well. Because if they don't drink good water, they will come down with illness. And you know, a pregnant woman is not like someone who is not pregnant, and she can easily come down with a disease. And if the environment is also such that mosquitoes can easily breed, then she can get malaria. Pregnant women get malaria quite often, and it may be more serious than in a non-pregnant woman. And that is why in our interventions, you realize that bed nets are given for pregnant women, and we also have tablets that we give them while they are pregnant before they deliver, all to help to reduce the incidence of malaria in them. So the environment and what we are in now affects the pregnant woman and the child.
For a region where we have the capital, Accra, perhaps the thinking should be that maternal health and the way it's provided should be the best among all the regions we have. Is that the case?
Well, we are told that Greater Accra is one of the safest places you can deliver.
Countrywide?
Yes. However, we still have maternal deaths, unfortunately. And we don't have 100% of our women delivering under skilled attendants. What we mean by that, a skilled attendant, is that either a midwife or a doctor, a trained person who has been trained in midwifery, conducts the delivery. If you look through our records, for example, we find that we don't have 100%. We have about 66%, which means that there's still the 34% who is delivering somewhere that we are not capturing. And I told you earlier that we capture figures from private facilities. However, that needs to be improved. The private facilities should give us every woman who delivers there. So we know that in Greater Accra, if we are taking 100 women who are pregnant, 100 of them are delivering by a skilled attendant. It's important because that is when you can easily identify a complication, or you can easily refer if you have to, or you can easily bring in an intervention. But if they are delivering somewhere that we do not know, then we are not sure what is happening to them or to their babies. Again, it is not enough just for a baby to survive. A baby has to develop. So if you deliver a baby who is alive but does not cry immediately, and nothing is done to help this baby to immediately overcome that challenge, then of course it can go on this baby.
Well, we'll talk about that, especially when there's birth and then thereafter what you do after 5 years. I think it's important because many of you are making a lot of sacrifices. And talking about sacrifices, well, we had to go into other parts of the region to try and gauge what the mood is, but more importantly, the level of sacrifices that are being made by a number of the health personnel and professionals who are sacrificing their own expertise, their own comfort to make sure that maternal health is improved and also mortality is reduced in many respects. And so we went to Shai Osudoku, and the main hospital there has Dr. Brightson, and Dr. Brightson is making enormous contributions to maternal health in the region.
This is the Shai Osudoku Hospital at Dodowa, a community located in Accra, Ghana. where Dr. Kennedy Brightson, the medical doctor in charge, takes care of all kinds of health conditions. Today, he starts work with a road accident, but this case has to be treated elsewhere.
We have been seen by the doctors and the nurses, and we are referring to that 7 for, because it's a compound fracture of the leg. There's an emergency at the liver ward, and I have to go right now, so I'll leave you. Thank you. Welcome.
Unobstructed labor. Together with nurses, Dr. Brightson delivers the baby.
Wow.
But unfortunately, she is lifeless. A quick attempt to revive the baby while mother takes a first look at her lifeless child. Many babies have died this way, but Dr. Brightson would not let go.
Okay, let's go. Let's go. Yeah, response coming. Yeah, baby has responded. Oxygen, please. I have a very strong passion for the health of women, pregnant women, and I think that as much as possible, it is important for every woman on this land called Ghana to have the opportunity to carry pregnancy and carry it to the end successfully. Come out, that the chiefs will say,
you will keep your child, your life after birth.
If a woman has to go through this kind of process, what it means is that no obstacle must be put in her way to achieve that. Hello. Thank you. You are cool. You are calm. I know you are not.
He has a long day ahead of him, but he takes time to encourage those on his waiting list.
2002, and you were fine, so you have come back again. Beautiful.
This helps in safe delivery.
Yes, and then, oh, you can lie down. Just lie down. Let's stretch your legs. Maybe I have to say.
Is everything okay? Why? You are looking so down. Are you hungry?
No, I'm feeling uneasy.
Oh, I see. Welcome to Kakra. Welcome to it.
On a daily basis, Dr. Brightson delivers about 10 babies. He has had to convert the corridor into a ward to accommodate the numbers. Yet, some mothers are attended to on the bare floor. This hospital sometimes runs out of basic supplies. Ghana has a national health insurance policy, but non-payment of health insurance claims has become another frustrating situation.
After crying and shouting, we were paid for March and April. Now, some of our suppliers chase me as though whatever we collected from them to use to save life, it is Dr. Kennedy Brightson that collected them for his private use. So they come to my house. Some come to my house, and some, anywhere they meet me, they embarrass me, they harass me. There was one gentleman who met me at Makola, and he embarrassed me very well. We have 6 months of money sitting with the National Health Insurance Scheme. Where do I get the money from? What do I do? 80% that come to the hospital hold this card. They hold this card. And we are supposed to see them free.
He is frustrated, but many pregnant women like Lucy built their hope on him. He delivered her 2-year-old son after losing 3 pregnancies elsewhere. Lucy is under confinement here now. Her 6-month-old pregnancy is a complicated one.
Being here is not easy, but I know at the end
I'll get what I want. And also, with God being by my side, I'll make it. Being here, I know I'll get a good result because it has always been good being at Dodowa, Shai Osudoku District Hospital.
Some patients are unable to afford food sold at the hospital. Dr. Brightson has to find a way to feed them. Today he is visiting one of the food donors who support the hospital.
Are you around? Today I came to visit. The plantain you gave us the other time was very helpful. We mostly gave it to the children. So I just came by to say thank you. How are you doing?
I am doing very well.
It seems the farm is doing very well.
Yes, the plants are looking fine because of the recent rains.
I hope you give this particular one to us.
Back at the theatre, the unending cycle of saving mother and child continues for Dr. Kennedy Brightson. This time, it is a cesarean session. Another successful delivery.
How are you?
I am fine.
Is everything okay? Did you see your child?
Yes.
And are you happy?
I am very happy.
Is it a boy or a girl?
It's a boy.
Ah, it's a boy.
According to the new report released by the Maternal Mortality Estimation Interagency Group of the United Nations, trends in maternal mortality 1990 to 2013, more than 3,000 women died from pregnancy-related complications in Ghana in 2013. His daily objective is to reduce the number before returning home.
So, now we finished with the second case, and we are left with 5 more to go. We will finish, emergencies will come. So, there are about 7. We'll have some emergencies as well. But we'll make sure that we save every single soul before we sit in our cars and drive back to Achimota in Accra.
Shai Osudoku District Hospital has not recorded a single maternal death in the last 2 years, thanks to Dr. Kennedy Brightson's commitment.
Well, so at Shai Osudoku Hospital, we had Dr. Kennedy Brightson also helping to do a lot more outreach and contribute to reduce maternal mortality in that part of the Greater Accra region. Well, we have the regional director in the studio, and we'll continue our discussions, and Dr. Linda Van Otu is still with us. Is that what you do regularly? Send out your topmost experts to go and assist in some of these deliveries and improve the situation in communities where perhaps there's not a lot more reach?
Well, let me say that the service has different grades of people. We have different grades, yes, if you like. We have the general medical officer who does everything. Then we have the specialist who specialize in very specific areas. So we can have obstetrician gynecologist who takes care of women. And then we have the pediatrician who takes care of children. And then we have the consultants in the various areas as well. So we work as a continuum. So if somebody goes to a facility and the doctor there finds that this is above me, the doctor can call somebody to ask for help, or if there's a senior person, not necessarily a consultant, not necessarily a specialist, but somebody who is proficient in that area, the doctor can call for help from that person, or the woman can be referred. So that is how we do it. But we also send out specialists and consultants to the remote areas to assist them. And they go and look at what they have done so far, discuss with them if they have had any challenges. And if there are any cases around, when I say cases, I mean people around, then they use opportunity to transfer skill. So if you have a case in theater, you have already started the operation, but you find that this is more than what I thought it was, then you can call for a consultant to come and help you. So whilst you are still operating, he will be there and he will do it and transfer skill to you. We also send them out to go and look at the records. Or if unfortunately we have a maternal death, then that consultant or that specialist is asked to assist to audit the death. And that will help to unravel any issues that needed to be addressed, which probably because the person did not know, was not able to address. And we use that to also make recommendations for improvement in the facility. So that is how we do it. But let me add that Ridge Hospital is the regional hospital for the Greater Accra.
Which one?
Our Ridge.
Formerly Adabraka.
Ridge Regional Hospital. It's not Adabraka is the OPD side or the addition or the polyclinic if you like. And we have Tema General Hospital, which also has the status of a regional hospital. And within these facilities, we have the specialists, we have the consultants. So those places are usually used for training as well. So we can have doctors in training who are sent there. If you want to become a surgeon, and because we have a surgeon there, the people who are training after medical school to become surgeons can be sent there to do that. And at the district level, like the Shayo Sudoku Hospital that we saw, Dr. Brighton is there, and he is in charge of the facility, the whole hospital. And he can do the cases that we saw. But if there's any case that is above or more than what can be handled at the facility, then it will be referred to Ridge or to Kolebu. And then we also have referral. Let's say that he's closed and he's gone home, and they have a case who is beyond the doctor who is on duty at that time. They can call him back, or the case can be referred to the Ridge Hospital to be managed.
If these are the contributions that, well, you are making as far as we're concerned to making sure you meet the objectives of reducing mortality as far as the issue of pregnant women is concerned, how do you tackle the issue of perhaps stillbirths? Do you have numbers? Do you get constant reports from the various satellite hospitals or health facilities that you have that these are difficulties? Not necessarily in the region, but if you go on your discussions as health experts, etc., you tend to do them.
Stillbirth is a big issue.
Why?
It's a big issue because some of them are not explained, not just here, even outside of the country. But for us in Greater Accra and also for Ghana, we have what we call the fresh stillbirth, and we have what we call the macerated stillbirth. The fresh stillbirth means that when the woman went into labor, the baby was still alive. But by the end of delivery, the baby did not breathe. So the baby was born dead, and that is what we call the stillbirth. And it is in pregnancies that are beyond where the baby could have survived. So let's say 28 weeks of pregnancy, and pregnancy is usually about 40 weeks. So 28 weeks, any baby born after that who dies or is born dead is a stillbirth. Now the macerated one, it means that this baby died in the mother's womb before she went into labor. And we are able to differentiate between the two based on the signs that we see on the baby. Or when the woman comes, we have to listen to see whether the baby's heart is beating. So when she comes and the baby's heart is beating, and of course the baby is alive. If it's not beating, then the baby is dead. If you look at Greater Accra, it's a big worry. We have a huge number, and most of it, more than 50–60% of it, the babies died before the women came in labor, which means that something happened between the last time they came for antenatal and the time they went into labor. Now, one of the things which I would wish that pregnant women would take note of is that the baby, when it is alive, moves in the uterus or in the womb. So if today you get up and you don't feel the baby moving, it means that the baby is going through a difficulty.
So you have to know.
Yes.
At least you have to know the movement
Yes.
of your pregnancy.
You see, the baby will move, and you find that at a point the abdomen will, or the stomach
somewhere will
swell up, or then you feel as if there's some movement. If today you get up and you realize that today I don't feel this baby moving, don't say that the baby is asleep, and that is it.
You mean the baby is inside, don't sleep?
No, they become quiet, but the women know that today I'm not feeling my baby's movement as I felt yesterday. Because as the babies grow, they become bigger. They feel the abdomen. And you feel the movement. Once if you haven't had a child before, that is different. But if you have had 1, 2, you should know that this baby is not moving so well. And then go to the nearest health facility so that they can assess the baby and see whether this child is going through trouble or not. When we count the baby's heartbeat, we'll be able to say whether this baby is going through a problem or is not.
But how do we perhaps juxtapose that with, well, the talk that always you need to constantly visit if it's your medical facility, to always get assessed. Now, if within the period of the 9 months of the pregnancy, you are always on time, you make sure you visit the antenatal, etc. And then, at which point would you be noticing these? Is he at home?
It can be anywhere. You see, the World Health Organization has found that if a pregnant woman visits the hospital at least 4 times during the 9 months, the outcome of the pregnancy should be better. In our setting, because of where people live and all that, and also because of what we can do and the numbers, we give them time to come. So if you are pregnant, within the first few months, you are asked to come every month. Then at a point, they'll tell you to come every 2 weeks, then every 1 week, to help us to assess you. But whilst you are at home, for example, if you feel that today is not my clinic day, but I'm not feeling my baby moving, you should go to the hospital, because looking through the literature, work that people have done, you find that that is one of the key signs that this baby is going through a challenge. So you need to go, they will assess to find out if this baby is actually going through a challenge which will end in a death, or the baby is okay. I would just add here that sometimes some women have gone and they have told them that everything is fine, but then when they went home and came back, the baby was not there. We are still in the process of looking at why are these babies dying. And we are talking of close to 2,000 of them.
Countrywide?
No.
Greater Accra?
Yes. So countrywide, we have that. When I was
You mean close to or just a little over 2,000?
It varies. That's why I use the 2,000.
Depends on which year. But averagely, over the last 5 years, it's been?
It's been about 1,900. And here it's the combination of the fresh and the macerated, as I explained, yes. And we are still trying to find, and that is why we are doing what we call the auditing. So we are auditing our stillbirth, and we are auditing even babies who were born alive but died within the first 7 days to find out what happened, so that we'll put in the necessary interventions. And to be able to address maternal health issues or newborn health issues or child health, it's not just the hospital. It is public health, it is clinical care. Because we need to tell the women the right thing. We need to follow up into their homes. We need to do public education. And these are the things that will help us. So we are combining all these things. And let me also add that we have what we call a call center, which will be starting very soon. And this call center, we actually need people to support us so that it will run well. I told you that we send out specialists, but sometimes in the middle of the night, a midwife may be conducting a delivery and she may fall into trouble. So we are setting up this call center, which is based at the Ridge OPD, Adabraka OPD. And this one, when she has a challenge, she will call to this place. And somebody will receive the call and ask what it is about. Then the call will be linked to a specialist who is on call that evening or that night.
This is real?
Yes.
Real time?
Yes.
Happens?
We are starting.
Oh.
We are starting February, this month. So we are starting on a pilot basis. And when that happens, that doctor or that specialist will listen and look at what is happening and give the necessary advice, or say that this woman should be referred to a particular place for the woman to be seen.
As we wind up our discussions, and I want us to touch a little bit on cancer and child cancer, because today is even said to be World Day on Cancer, so to speak. But as far as this is concerned, how many of the numbers have you recorded over the last year?
For the stillbirth?
No, not necessarily.
Oh, the cancers?
The maternal mortality.
Maternal mortality in 2014, adding Kolebu, we have 204.
For the region?
Yes, Kolebu recorded 77.
For the region?
Yes.
Could there have been some numbers perhaps have not gotten into the public health system? Either in the villages somewhere?
It may be possible. If a woman does not deliver at the hospital, delivers at home and dies, then we would not know. And as I said earlier, our skilled delivery for last year stood at 66%. So there's a 34% that probably delivered in a private facility or delivered somewhere else that we haven't captured. But what we have in our documents is the 204.
Well, prior to today, we had to do a lot of reading on the subject. On the UN website for Ghana, what they put there as far as the reduction from 1990 to about 2013 was 49%. Is that the same figure you also tend to work around nationally?
Yes, nationally, as I told you, we have reduced, yes. It has come down.
Is that significant enough, 49%?
It is. You see, 49% is, because as I told you, it is not easy to reduce one maternal death. It is a whole lot of issues together. The patient herself, the family that she's in, the health system, the environment, the place where she is, how to get to the facility, the money to take. So many things that have been put together as the 3 delays. But I add other things, that at the health facility, we need to consistently look at the records, and then we need to consistently use our protocols that we have. So the delays are there, yes. The woman, even deciding to go, she can delay. When she decides to go, getting there, she may delay. Yes, because she may not have money. There may not be anybody at home to take her. She may not have the transport to go. And then when she gets to the hospital, the speed with which we do this, or when we get things going, may also delay. So these 3 delays have been identified, but they go beyond.
But there are a number of factors that could lead to the speed reducing at the health facility, etc. Either because congestion or overload of cases or emergency.
Yes, we are hoping that RIDGE will finish soon. Then we'll have more space. But for now,
you see, you guys in the health sector seem to make RIDGE as the panacea to resolve.
No. They are building a new. You know that they are putting up a new facility.
That very facility.
We don't have a lot of space. From the Shayo Sudoko, I'm sure you saw some of the.
Yes,
if you go to Tema General Hospital,
terrible.
Yes,
I've been there several times.
And it's the same for even Kolebu and other places. So when this new building is put up, we hope that we'll have extra space to.
As far as cancers are concerned, we're told now children are also getting very much diagnosed with cancer.
Yes.
Why is that?
Well, cancers, some of them can be explained, others cannot be explained.
Actually, so many of them can't be explained.
Yes, so it depends. But we have cancers in children, and some people don't even know that children get cancers. And I had a chat with the people who take care of them. In Ghana, we have the 2 main teaching hospitals, Kolebu and Konfanochi, are the 2 main places where they take care of the cancers. So you can imagine the delay. And we are also informed that they have, well, if you look at it, maybe 1,000 cases. And we have...
what, 1,000 cases per year?
Yes, of these cancers.
That they have to treat?
Yes. And they are able to treat some of them, and averagely it costs about 1,000 too. We try to find out how much it costs to treat, and it's about 1,000 too.
That's the minimum?
Yes. And some of the people start the treatment, and once they see that there is reduction or remission, then they stop, forgetting that it may come back. But if these cancers are well treated and they follow the treatment, then these children can live for many years. 60 years, they can become adults, have normal lives and all that.
They can?
Yes, but some of them come very late. For example, if somebody sees a swelling, they might think that this is a boil, when in actual fact, it may be cancer. So the good thing to do is to go to the nearest health facility. Yes, today they are launching the cancer, today they are launching it in Accra. And on the 16th of February, they will do the one for the children.
Last question. There's always a myth about cancers, especially in the developing world. Is it that because we now have better health systems, and so the reporting lines are now structured and are now more visible or vivid? As a result of that, we're getting to know a lot more of the cases compared to what happened 20, 30, 40 years ago.
Yes, because now we also have people who have been trained to manage them.
Okay.
You see,
so cancers have always been with us?
Yes, they have been. And
I thought they've got to do with lifestyles and things like that.
Well, the children haven't really lived long to be
so that one
lifestyle.
we can't explain.
Yeah, some of them cannot be explained. Others too, they start with something else. For example, somebody can have cancer of the kidney, or they might have cancer on the, you can see it on the face. Not associated
with any lifestyle at all.
No, they are, yeah, some of them may be because they were born with something that turned into that, or it may be that something else happened from the environment that led to that.
Okay, well, thank you very much. Dr. Linda Van Otto is the Regional Director for the Ghana Health Service, Greater Accra. And let me just leave you with this. According to a report, globally, maternal mortality has reduced by some 45% between 1990 and 2013, and just in 2013-2014 was estimated that between 289,000 and 300,000 women, well, they recorded stillbirths. And so it's an issue in sub-Saharan Africa. But there's been some significant improvement in countries, and respective countries like Equatorial Guinea, Cape Verde, Eritrea, and Rwanda are the 4 African countries described as on track to meet the Millennium Development Goal 5. Well, Equatorial Guinea, we're going to play them tomorrow, the Black Stars, right? All right. So in the meantime, though, we're taking a break. When we come back, we'll have a lot more for you.